Neurology quiz number 106. Describe the clinical features, pathogenesis, and treatment of the various types of episodic ataxia or EA. The episodic ataxias are a group of disorders characterized by recurrent spells of truncal ataxia and incoordination. Most cases are genetically determined and have an autosomal dominant inheritance pattern. The incidence is likely to be less than 1 in 100,000, but it may be underestimated due to underutilization of genetic testing and unidentified causative genes. The group comprises 8 subtypes, EA1 to 8. EA1 and EA2 are the most common. They have well-defined phenotypes and have been reported in multiple families of different ethnicity. This figure shows the genetic mutations associated with the different kinds of episodic ataxia. Episodic ataxia type 1. EA1 is due to mutations in the potassium channel or KCNA1 gene. De novo mutations may occur. KCNA1 is located on chromosome 12. It encodes the voltage-gated potassium channel Kv1.1, which is expressed highly in basket cells and interneurons forming the GABAergic synapses on the Purkinje cells of the cerebellum. Onset is typically in childhood and on average at age 7 to 8 years. Brief attacks of ataxia and vertigo are typical. The core features are imbalance in coordination and slurred speech. Triggers include physical and emotional stress, startle response, or abrupt movements. The typical duration of attacks lasts seconds to minutes, but prolonged attacks lasting hours or days have been described. In rare cases, permanent cerebellar dysfunction may occur. This slide shows the structure of the Kv1.1 subunit of the voltage-gated potassium channel. The voltage-gated potassium channel consists of 4 subunits. Mutations associated with episodic ataxia type 1 are shown. The attack frequency can range from multiple daily attacks to monthly attacks. During the attack, gait impairment may range from mild dysfunction to complete inability to walk. Constant myokimia of the face or limb muscles, detected clinically or via EMG, affects almost all patients. Neuromyotonia may occur and is characterized by muscle stiffness, twitching, and muscle hypertrophy. Additional symptoms include headache, diplopia, distal weakness, tremors, choreoathetosis, and cognitive dysfunction. Most patients are normal between attacks and have a normal MRI brain. However, longer disease duration is correlated with permanent cerebellar signs and cerebellar atrophy. Diagnosis. This is based on clinical findings, electrophysiologic studies, and genetic testing for the KCNA1 mutation. Treatment. Some patients do not seek treatment because attacks are brief and improve with age. Anti-seizure medications like carbamazepine, phenytoin, and lamotrigine can reduce attacks, and carbamazepine can also decrease myokimia. Rarely, acetazolamide and benzodiazepines are helpful. However, response to medication is highly variable and drug-resistant phenotypes are encountered. Episodic ataxia type 2. This is the most common type of episodic ataxia. It is caused by mutations in the calcium channel gene or CACNA1A. Mutations in this gene also cause familial hemiplegic migraine and spinocerebellar ataxia type 6. CACNA1A is located on chromosome 19 and encodes CAV2.1, the alpha-1 subunit of the PQ-type voltage-gated calcium channel. This channel is widely expressed in the Purkinje and granule cells of the cerebellum. This figure shows a scheme of the human CAV2.1, highlighting the position of mutations causing episodic ataxia type 2. This figure shows a section of the cerebellum showing the location of the granular cells, Golgi cells, and the Purkinje cells on which the potassium channels and the calcium channels are located. Clinical features of episodic ataxia type 2. The onset is typically early in childhood, but patients with an onset during the 6th decade have also been reported. Attack triggers include emotional or physiological stress, exercise, alcohol, and caffeine. Features include intermittent spells of ataxia and dysarthria, lasting several hours, possibly up to 2 to 3 days. Interictal nystagmus between attacks is a useful clinical clue. Migraine is reported in up to 50% of cases and may be hemiplegic migraine. Other features include brainstem symptoms, seizures, generalized weakness, dystonia, and cognitive impairment. As in episodic ataxia type 1, some patients develop a progressive cerebellar ataxia syndrome and cerebellar midline atrophy. Diagnosis is made by a combination of clinical features and confirmed by genetic testing. Episodic ataxia type 2 is distinguished from the other episodic ataxias by attack duration and interictal nystagmus. Treatment: Acetazolamide can reduce or completely abolish attacks, but the mechanism of action is unclear. About 50 to 75% of patients report improvement with 250 to 1000 milligrams daily. The potassium channel blocker 4-aminopyridine 5 milligrams TID is also effective, reducing the number of attacks and improving quality of life. Fampridine, which is a slow-release formulation of 4-AP at 20 milligrams per day, also reduces attacks, and these medications are better tolerated than Diamox. Other episodic ataxias 3 to 8. Episodic ataxias 3 to 8 are reported in rare families. Genes have been identified for episodic ataxia 5, episodic ataxia 6, and episodic ataxia 8. Causative genes are inconclusive or not known for episodic ataxia types 3, 4, and 7. Clinical features include episodic ataxia, dysarthria, vertigo, as well as interictal nystagmus and myokimia. Associated features include seizures and migraine. Some of these cases may respond to acetazolamide.